Good afternoon, and welcome to our series of webinars focused on bringing you information about COVID-19 related topics. The information in these weekly webinars is geared toward long-term care and skilled nursing facilities, but we encourage everyone who's interested to attend. My name is Kathy Caudill. I'm a communications specialist with Quality Insights. Today, we'll be discussing awareness and resources for post-COVID syndrome in the outpatient and nursing home settings. Everyone has entered the meeting on mute, but we will have a discussion following the presentation. If you have questions or comments, please submit them using either the chat or the Q&A tool in your Zoom menu. And you can also raise your hand to request to be unmuted to ask your question out loud during the discussion period. We invite you to join us every Wednesday at 2 p.m. for more of our weekly webinars. Next week, we'll be having a special webinar on the end of the public health emergency, breaking down the guidance for long-term care facilities, home health, and hospice. That webinar will be eligible for nursing CEs, and it will be the same time and place next Wednesday at 2 p.m. I will drop a link in the chat shortly with more details about how to register, about the CE information, etc. And now I'd like to introduce our guest today, Dr. Jean Storm. Dr. Storm is Medical Director here at Quality Insights. She has a background in nursing home care, internal medicine, and healthcare leadership. She recently served as Associate Medical Director for Optum United Healthcare. She has also served as Regional Medical Director for 38 long-term care facilities in West Virginia. She earned her DO from Lake Erie College of Osteopathic Medicine and completed her postgraduate training at Mill Creek Community Hospital in Erie, Pennsylvania. Dr. Storm, thanks for joining us again today.
Thanks, Kathy. So today we're going to be talking about post-COVID syndrome, and you're going to be hearing me talk about it in using different labels. And I'm sure you've heard that it be referred to by many different labels. And we're going to be kind of using those interchangeably. I just want to say that I don't feel the labels are really important, but I think it's important that we recognize the symptoms of post-COVID. I think that they are definitively under-recognized. And I just wanted to point this fact out because we can't treat something as another type of disease process and give somebody a medication perhaps, and then, expect it to change if it is post-COVID syndrome. So we're going to be talking about awareness and what we can actually do to help patients if we suspect this. So the objectives, we're going to be talking about the definition of post-COVID syndrome and its symptoms. We're going to be able to recognize that individuals at risk of developing post-COVID syndrome, as well as the prevalence of post-COVID syndrome. We're learning a lot, and we're realizing that the prevalence is higher than we thought. We're going to be talking about the lab tests and assessment tools that should be done if you suspect someone is suffering from symptoms of post-COVID syndrome. We're going to be talking about the surprising role that the COVID vaccine plays in post-COVID syndrome. Now, I know we've talked about the vaccine a lot, but this is a really surprising way that we can perhaps ameliorate symptoms in post-COVID syndrome. We're going to be talking about the general treatment approach of post-COVID syndrome. We're going to be also talking about health inequities. We know that health inequities played a really big role in COVID infection. So therefore, we know that health inequities continue to play a big role in post-COVID syndrome. We're going to also be talking about COVID cognitive bias. Cognitive bias in healthcare is something that I'm really interested in how important a role it plays in how we see our patients and how we make treatment decisions. Our cognitive biases really affect our patients more than we think. So we're going to be talking about these biases. And then we're going to be talking about the role that post-COVID syndrome is playing on healthcare workers and staffing stability. It's pretty significant. So just starting out with a case, this is an 82-year-old male, and he presented to the ER due to chills and shortness of breath. He's diagnosed with COVID-19 and admitted to the hospital due to hypoxia. He's treated for 5 days with remdesivir and dexamethasone, and he's discharged home with oxygen, which is eventually able to be weaned off. Over the next 6 months, his wife brings him to his primary care physician several times due to his memory issues. She's saying that he doesn't remember things as he should. He doesn't recall names as he should. And 9 months after his hospitalization, he presents back to the ER due to slurred speech and left-sided weakness, and he is diagnosed with ischemic stroke. So this patient, I feel, is really significant and really illustrates what I think is happening with post-COVID syndrome. It's this slow deterioration that patients are having after they had a COVID infection. And, because these patients have a chronic disease, they have many chronic diseases, these symptoms might be thought of to be due to their chronic diseases, but they have a significant deterioration. And it's a slow deterioration. In this case, it was 6 months that this patient deteriorated. So it's really easy to write it off as perhaps he has dementia, all of these things. But now we see that he had a stroke. Now we know that stroke and other cardiovascular events there's a significant risk in the year following COVID diagnosis. So this is something we really have to pay attention to with our patients and really keep an eye on, because potentially we could prevent them. So this is me I was actually in the COVID unit at the hospital where I was seeing patients, and I just felt really hopeless at the time. We know that the public health emergency is over. So a lot of us think that we're out of the woods with COVID, but we have a lot of people, patients, individuals who are still suffering from effects of long COVID. And I know in many long-term care facilities, we're still experiencing COVID outbreaks. So especially in the long-term care world, we are certainly not out of the woods yet with COVID. And my concern is that now the public health emergency is over and that spotlight is kind of off of COVID, that it's going to continue to run through nursing homes and run through really vulnerable populations of people. And we need to be vigilant of this fact and think about the misinformation that is going around surrounding vaccinations. I really am going to be honest. I feel that our long-term care population has been thrown to the wolves of misinformation in our society. And it's really our job to do our due diligence to protect these individuals. They're certainly the most vulnerable in our society. So that's what I'll be talking about today. So we talk about COVID numbers. These I pulled from the CDC COVID data tracker. You can see it, I pulled it from April 21st, 2023, so a couple months old. What I wanted to kind of point out that we have a really low uptake of our booster, 16.7%. It's fairly low. We know that in vulnerable populations, the booster does a really good job of protecting individuals. I recently was listening to a webinar just specifically on the booster effects in long-term care, and they're really able to protect people. Still, they provide a really good protection against mortality. In individuals who are over 80, if they are unvaccinated, there's still at 1 year a very high risk of death associated with COVID. Still, these are with patients who are obviously very vulnerable. So we really have to continue to do our due diligence for getting patients up to date with their bivalent vaccine. And you can see all of the numbers there. And then these are the numbers in the nursing homes. If you look at the number of, first of all, you can see obviously the vaccinations for staff and for residents. And then if you look at the total resident COVID-19 confirmed cases, it's high, right? Very high. So when I think about this, we're not talking about long COVID in the nursing homes. Not very many people are talking about long COVID in the nursing homes. So I think that this is something that we really need to think about. Why aren't we talking about long COVID in the nursing homes? We certainly have a huge number of individuals who were diagnosed with COVID. So just a few thoughts on the numbers. I don't like to get tied up on numbers. I really like to look at the individual. But when we think about numbers, you might say, oh, well, my region wasn't very high. You know, states and territories, they track data in different ways. So there's also some controversy as to what constitutes a death from COVID infection. I've filled out many death certificates from COVID and have been questioned about quite a few of them. So I know that there is controversy. Personally, I know there's controversy around what constitutes a death from COVID. And then not all states report hospital admissions, the intensive care unit, all of those, they're not all reported the same. And then we have the issue of multiple positive tests. So I will say we really need to look at each individual and look at symptoms and think, if this individual did have COVID in the last few months, could the symptoms be due to long COVID syndrome? So case number 2, 89-year-old female, long-term resident of a nursing home, develops fever, chills, and cough. She's diagnosed with COVID, but is not requiring oxygen. So she's treated symptomatically in the facility. She complains of fatigue, dyspnea, and depression 1 month after her COVID diagnosis. She continues to complain of these symptoms for the next 2 months. She eventually becomes bedbound due to depression and fatigue. And then later she is found to have a stage 3 decubitus on her sacrum 4 months after her COVID diagnosis. So this is a case that could happen in any facility. And we could attribute these symptoms of fatigue, dyspnea, and depression to long COVID. And then we could tailor our approach to this individual if we were aware that it could possibly be that. I just wanted to point out this article was published in the Atlantic. Ed Young has done a really great job at bringing to light some long COVID issues that I think society would rather not deal with. And this article is really interesting. I think a lot of people want to forget that long COVID exists. So when we talk about post-COVID syndrome definition, post-COVID conditions, it's like an umbrella term. There's a lot of symptoms that are under post-COVID conditions, and it's a wide range of physical and mental health consequences. It is present in patients 4 or longer after 4 or more weeks after initial COVID infection. And this is, it's more common if patients have had severe COVID, they've been in the hospital, and of that sort of infection. But it's also present in patients who've had a mild or asymptomatic acute infection. So no one is spared. So the best way to prevent long COVID is to not get COVID. So getting vaccinated is always the best course of action. More recently, some scientists have been pushing to relabel long COVID or post-COVID syndrome as post-acute sequelae of SARS-CoV-2 infection, or PASC. There's been a really great series of articles in JAMA recently of the work that is being done to gather information about PASC, because we really don't have a whole lot of information. Most people who have COVID recover within 4 weeks, but some individuals continue to have symptoms for a very long time. Another case, a 51-year-old female presents to her primary care physician with a complaint of fatigue and headache for 2 months. She was diagnosed with acute COVID 3 months ago and was able to manage her symptoms at home during quarantine. She says she's missed several days of work due to fatigue and had to stop her exercise program. She's been taking ibuprofen and acetaminophen for her headaches, but they've not been affected. So this is a patient that really needs support for her long COVID syndrome symptoms to really figure out what she should do. So labels, as I was talking about before, there's many of them: long COVID, post-acute COVID-19, long-term effects of COVID, long-haul COVID, late sequelae of COVID, and then PASC, post-acute sequelae of SARS-CoV-2 infection. I speculate that we will probably be using PASC going forward, that last term. because there's been so much research around it, and that is the term that's being utilized. There are so many ongoing studies right now about this syndrome. So what about numbers? Long COVID has been estimated to affect 23 million Americans. So that's a large number of individuals. So it's not something that really should be dismissed. It can, again, follow both non-severe, mild asymptomatic, or severe acute COVID-19 infection. And studies in the US estimate that 10 to 30% of COVID survivors develop long COVID. So even if it's just 10% of individuals who had COVID, that's a huge number of individuals. And there's some individuals that may have symptoms, they're afraid to go to the physician, they're really suffering, and they don't even acknowledge that potentially it could be long COVID. Maybe they're looking at other things or thinking they have other things, when in fact it is symptoms may be due to long COVID. So we talk about prevalence studies. A study of 410 individuals in Geneva, Switzerland, they tested positive for COVID in 2020. These individuals reported to have mild or moderate COVID-19. 39% reported that they had some symptoms at 7 to 9 months after COVID. This is so significant. Most common symptoms: fatigue, loss of taste or smell, dyspnea, and headache. Fatigue is really significant. And when you think about older adults, we know that when older adults have mobility impairment for whatever reason, this is when they start to deteriorate. This is when they start to need more help at home. This is when they start to have falls at home. This is when they start to be unable to perform their ADLs. This is when they might need to go into a nursing facility. So this is why this is so important, and that we're vigilant and making sure that these individuals get the support that they need. So the COVID symptom study is a mobile application. It was launched in response to the COVID-19 pandemic. Data was analyzed from a little over 4,100 incidence cases of COVID-19. So that's a lot. The individuals were given access to a COVID symptom app where they could plug in each symptom that they were having. And 13.3% of participants reported having symptoms lasting greater than 28 days. 2.3% had symptoms greater than 12 weeks. And again, the long COVID symptoms were fatigue, headache, dyspnea, and inability to smell, and was more likely to be associated with patients who were female, were older, and had a higher body mass index. So we talk about long COVID in nursing homes. This was a single study that was done in an Italian nursing home. We know that there were a large number of COVID cases in Italy, especially in nursing homes. And so this was the Gemelli Against COVID-19 Post-Acute Project in Rome, Italy, and 165 individuals. They were 65 years and older. This is really significant that more than 80% of the patients reported persistence of at least one symptom at 90 days after the hospital admission. And again, we're looking at fatigue, dyspnea, joint pain, and cough. So fatigue, significant in the nursing home. I think it's something that we kind of don't think about as important, but it certainly is. So again, the common presentation, as I mentioned, dyspnea, fatigue, post-exertional malaise is really significant. There's been a lot of research around what type of physical therapy is most appropriate for individuals who have post-COVID syndrome, especially in nursing homes, because we want to make sure that if an individual needs therapy, that they are given just the right amount. We know that too much can cause this post-exertional malaise. Not enough is not going to really be able to rehabilitate somebody and get them back to performing their ADLs. So that's definitely needs more research. Cough, chest pain, headache, abdominal pain, myalgias, diarrhea, insomnia. Interestingly, there was a study recently that was published, and researchers are still looking at water sewer water to detect how high the levels of COVID is. And there is a large amount of COVID present in a place in Ohio, in a county in Ohio. And the individual researcher said that he speculates that there's one individual that probably is having a significant gastrointestinal upset. And this has been months. So some individual in Ohio is obviously suffering from perhaps diarrhea for months due to their COVID infection, insomnia, fever, pain, rash, mood changes, palpitations. We're going to talk a little bit about palpitations and tachycardia. So this is just a slide that kind of summarizes all of these symptom manifestations of PASC. And you can see that it covers many, many, many organ systems and are fairly significant. Cognitive impairment is really huge, neurologic. I think a lot of individuals are being misdiagnosed as having Alzheimer's, and perhaps they have cognitive impairment associated with post-acute the long COVID syndrome, gastrointestinal loss of appetite. So we could have patients who are losing weight and we're not sure why. Any kind of changes, a lot of changes in the gut microbiome. There's a lot of research that's being done right now on the gut microbiome and the significant role that it plays in our health. Pulmonary, again, I talked about dyspnea and cough. Pulmonary fibrosis, really interesting. Perhaps if an individual had pulmonary fibrosis, it would worsen this diagnosis. Again, chronic fatigue, kidney injury we've seen. So maybe these patients are being misdiagnosed, with dehydration and they have long COVID syndrome. Psychiatric issues are a big problem. And then cardiovascular, a huge problem, tachycardia, palpitations, and then this postural tachycardia syndrome, which is really debilitating for patients. I thought this was really an interesting study. They looked at 80 COVID survivors between 59 and 73, and they looked at hand grip strength and vastus lateralis muscle cross-sectional area. So they were looking at an individual's muscle mass, and hand grip strength is a really important indicator of even just mortality in patients, because we know sarcopenia or loss of muscle mass plays a huge role in chronic disease and mortality. But in this study, if an individual had a greater loss of muscle mass during their COVID diagnosis, they had higher total COVID-19 related healthcare costs. And these individuals had higher levels of fatigue and myalgia. So what this says is we really need to do a good job of rehabilitating patients, getting them in physical therapy, really trying to maintain their muscle mass when they have COVID-19 and making sure patients are getting enough protein. Very important. Postural tachycardia syndrome. Some individuals have symptoms of shortness of breath, palpitations, and chest discomfort with orthostatic tachycardia post-COVID. So this combination may be a manifestation of postural tachycardia syndrome, mainly affects women, but obviously could affect anyone. And this is debilitating. And so this is something you really need to think about, especially in our nursing home patients. If they're getting dizzy or lightheaded, so maybe getting their vital signs orthostatic, so sitting, standing, lying down, to see if this could be occurring. This study was just released, very interesting. It looked at a lot of patients, 125,000 individuals who were COVID positive. Individuals, mostly males, had a higher incidence of diabetes after their COVID diagnosis. So, and I love this quote, SARS-CoV-2 infection may be associated with a higher burden of diabetes at the population level. So this means that we really need to do increased screening in these individuals for a year after they have the COVID infection, because obviously you can see that if an individual had COVID, they have a higher risk of diabetes following their infection. I was recently watching a webinar, and there was a gastroenterologist on the webinar talking about COVID and long COVID in susceptible populations. And he said a quote, which I really liked. He said that we thought that this COVID was a respiratory infection. And now we are learning that it is not just that. It is affecting individuals across multi-system, multi-organ. So when we talk about gastrointestinal issues, this was a study that was done in the Department of Veterans Affairs. Another large study, 154 people with COVID-19. After the first 30 days of infection, individuals who had COVID-19 had increased risks and 1-year burden of gastrointestinal disorders. So this means, so this is at a year, these individuals had increased risk for cholangitis, peptic ulcer disease, pancreatitis, gastritis, and others. And the worse the COVID infection was, the more severe the symptoms were. So again, startling. Psychiatric issues associated with long COVID. This was a meta-analysis of studies around the world showed that the overall prevalence of depression, anxiety, and sleep disturbances among COVID-19 survivors is really high. So 45% for depression, 47% for anxiety, 34% for sleep disturbances. I thought this was really disturbing. A study of 236,379 adults with long COVID demonstrated that the estimated incidence of a psychiatric diagnosis after 6 months was 34%. 13% of these individuals got their very first ever psychiatric diagnosis. So startling. And the researchers concluded that the psychiatric sequelae of COVID-19 appear widespread and to persist up to and probably beyond 6 months. So again, we think about COVID's impact on the brain. Neurologic conditions occurred 7% more in patients who have been infected with COVID compared to those individuals who have never been affected. So 6.6 million people who have suffered brain impairments associated with COVID. So long COVID patients have increased risk of cognitive deficit or brain fog, which could be misdiagnosed. There's also a higher increased risk of dementia, psychotic disorders. So when we're talking about reducing antipsychotics in the nursing home, this could play a role. Epilepsy, seizures compared to other respiratory infections. So again, something to be aware of. So when we talk about what do we think that the possible causes are of post-COVID syndrome. So researchers think that it's due to organ damage resulting from acute phase infection. And then we know that there's an issue with dysregulated inflammatory state. So we get this inflammatory state and we have an infection. And it's thought that COVID sometimes causes a dysregulated inflammatory state, that it goes really on high alert when it perhaps doesn't need to be on as high alert. They also think perhaps that it's due to ongoing viral activity associated with a reservoir somewhere in our bodies. And in fact, maybe that's why the COVID vaccination helps with symptoms of long COVID in some individuals. They think perhaps autoimmunity, perhaps that there's an inadequate antibody response to the infection in the first place, or other potential cause. Research is ongoing. So individuals at risk, I'm going to say all individuals at risk, but these individuals have been shown in research to be at highest risk of long COVID syndrome. Female sex, older age, individuals who have pre-existing conditions at time of infection, which is almost every single older adult. The severity of the initial infection, though I said mild to moderate infection, has also caused long COVID. We know that individuals who have severe infection are at higher risk of experiencing post-COVID syndrome. And those individuals that are infected and don't get vaccinated, there's an extremely high risk of long COVID, post-COVID syndrome. If you get COVID and you are not vaccinated when you get the infection, especially in individuals over 80. The data is just astounding. And I feel like more people should be talking about it. So drivers of increased susceptibility. So we know that there are certain individuals who are more at risk. And when we think about why, we talk about racial and ethnic minorities. These individuals are at increased risk of exposure and to have manifestations, severe manifestations of COVID-19. They might have socioeconomic factors that prevent self-isolation. They might have lack of access to care. So we're going to be talking about social determinants of health and how these impact susceptibility to long COVID syndrome. There's distrust of medical institutions. And as providers, this is where we can really play a role in saying to patients, I believe that you're having symptoms and I want to get to the bottom of it, just as you do. Older population, we talked about individuals who have a high rate of pre-existing conditions, individuals that have clinical complexity, obesity, diabetes, heart, lung disease, multimorbidity, if they have severe COVID-19 manifestation. Rural residents, interestingly, also have increased risk for severe COVID-19. They don't have as good a healthcare and infrastructure, perhaps, in a rural area, and they have a high rate of pre-existing conditions. So another case, a 48-year-old female presents to her primary care physician with fatigue and dyspnea on exertion for the last 4 months. She was diagnosed with acute COVID 5 months ago and required hospitalization due to hypoxia and respiratory failure as her asthma symptoms worsened with the infection. She's a single mother, taking care of 4 children and her father who has dementia. She works a physical job and has been unable to work for the last month due to her symptoms. She states that she is stressed and anxious due to the current situation. So this is a patient that needs support. She needs resources. We're all here in this society and we really need to take care of each other. It does no one any good to tell this individual that her symptoms are fake, that she is faking it. That should not be our approach. We should support all of our members of our society and believe what they're telling us. So the economic impact in January 2022, the Brookings Institute looked at a meta-analysis, and it suggested that long COVID may be responsible for over 1 million workers being out of the labor force at any given time. So that is a lot. So there was one study that was done of nearly 4,000 long COVID patients, and then they found that 45% reduced their work hours. So the Department of Justice and Health and Human Services has issued guidance stating that the condition can be a disability under the Americans with Disabilities Act. So that is good. I'm gonna move the face shots. This chart consists of a single panel showing the share of clinical population survey respondents who are out of the labor force due to disability or illness. This is at a monthly frequency from January 2017 through June of 2022. So you can see it was in steady decline of individuals out of the workforce. So before the pandemic, and then it kind of went up a little bit. So as you can see, the trend in decline in disability is kind of stalled out. And this is most likely due to long COVID. So we talk about evaluation. What can we do? We need to do basic lab tests. We need to get a blood count, CBC, electrolytes, or BNP and CMP, or renal function. We need to look at our liver function. We need to look at our inflammatory markers, or CRP, C-reactive protein, ESR with our erythrocyte sedimentation rate, a ferritin. We need to look at our thyroid function, and we need to look at vitamin deficiencies and make sure that an individual isn't having vitamin deficiencies, which are contributing to their symptoms. There are screening tools that are available to screen individuals for long COVID or post-COVID syndrome. There is the Patient Reported Outcomes Measurement Information System, the PROMIS. There is a post-COVID functional status scale, the PCFS. There's the EuroQol-ED EQ5D. And then under neurologic, we can use the MMSE, we can use the MoCA. And then we can also, of course, screen for psychiatric conditions, for PTSD, the GAD-7. The GAD-7 is for anxiety, PHQ-9 is for depression. There's also the fatigue severity scale, very important. And then other screening, we would test for exercise endurance for patients and balance. Really, balance screening should be done very frequently. I think in older adults, it's not. Falls are just a significant cause of death. So we really should be testing individuals' balance and working on that in therapy if we can. So this is the patient self-reported, the post-COVID-19 functional status. So this is the PCFS scale, and it's a flow chart. So you can kind of just start. Can you live alone without any assistance? And then you can kind of see, you can go through it. And then if you can grade the individual depending on what their answers are. And then you can look at, from the corresponding PCFS scale grade. I have negligible limitations in my everyday life. And then you can see everything on the scale. This is really interesting. I had a family member who had COVID twice, an older individual. And as a physician, I get asked questions from family members, which I have a hard time because I don't know if it's actually the right thing to give a lot of medical advice to a family member. But this family member has had a significant decline over the last 6 months to a year since the last COVID diagnosis. And I've been thinking about post-COVID a lot, and I was talking to this individual, and I said directly, have your symptoms, which are fatigue and shortness of breath, I said, have your symptoms impaired your ability to do the things that you normally do in your life? And he said, oh, yes, 100%. And no one has diagnosed him with post-COVID syndrome. Everything else is being looked at. Medications are being added, but there's no screen for post-COVID syndrome. So I really think about how many other individuals are falling through the cracks because we're not doing a screening such as this. Have you had to limit your activities of daily living? Which is a very simple thing to ask. So I would highly recommend doing a screening like this one. So let's talk about treatment, because we know it's a problem. We know that there are a lot of people affected. So what can we do? So treatment should focus on the goals of improving function and quality of life and really meeting the individual where they are and then attempting to improve their function and quality of life. It's really important to be transparent with patients and say, we don't know a whole lot. This is not well understood. Research is ongoing. I want to help you in any way I can. Symptoms should never be dismissed. We don't realize as healthcare providers how much our words have an effect on patients, and the nocebo effect, meaning, you dismiss somebody, it can actually cause them to have worsening of their symptoms and distrust the healthcare system. And then they don't get the screenings, the basic screenings that they should, like a mammogram, a colonoscopy. So it is our duty to not dismiss patients. I would recommend using the shared decision-making tool. Really wonderful approach, sitting down with the patient, asking for their participation, talking about treatment options, exploring the treatment options with them, reaching a decision with your patient together, and then evaluating the patient's decision. So really simple approach. Vaccination. I'm going to talk about vaccination. This is an observational study. There have been many more that have been published, but this one was very interesting. This was a study of 812 individuals experiencing long COVID symptoms. 72.4% had experienced their symptoms for more than 9 months. That's a long time. Most of them had mild or moderate symptoms. 10% required hospitalization for their COVID infection. Symptoms were measured by a survey before and after they got the vaccination. So these individuals were not vaccinated when they got COVID. They got their COVID diagnosis. They continued to have long COVID symptoms, and they agreed to be part of this study. They got vaccinated. And as you can see, for this study, 56.7%, so more than half of the individuals saw an improvement in their long COVID symptoms after they got vaccinated. So something to think about when we are giving education to patients and families. And I wanted to just bring this study up. This is a very unique study because I've been thinking about vaccine hesitancy a lot. So this was a study by involved a lot of individuals, over 11 million individuals, and they looked at vaccination status and traffic crashes. And you might say this has nothing to do with long COVID, and it really doesn't, accept the fact that vaccines have been shown in some individuals to improve long COVID symptoms. And we know that if an individual is vaccinated when they get COVID, there is a less risk of them developing long COVID. So in this study, unvaccinated individuals had a 72% increased relative risk of traffic crash compared with vaccinated individuals. I think that sometimes it's really hard to get through to individuals about vaccines. And this might be a study that, even if it gets through to a certain number of individuals, it might just say, like, if you resist public health recommendations, you're also more likely to neglect basic road safety guidelines. So just something perhaps to keep in your back pocket. It's in my back pocket. So treatment approach, cognitive. If the cognitive screening is positive, you want to think about referring an individual to a speech language pathologist, an occupational therapist, a neuropsychologist, so they can recommend tactics to help these individuals cognitively rehab. We want to talk about sleep hygiene techniques, very important. Talk about sleep hygiene techniques. We want to treat a mood disorder. We want to treat pain. We want to do all of these things and treat these underlying medical issues. We want to relook at the medication regimen. We want to deprescribe if we think perhaps the medications may be worsening any of the symptoms. And then once individuals return to baseline, encourage regular exercise. Like I was talking about, health inequities, acute COVID-19 is associated with significant racial disparities. Black, Latinx, American Indian, Alaska Native, Asian, Native Hawaiian, and Pacific Islander, and other non-white racial groups are less likely to have access to testing, more likely to be infected, more likely to be hospitalized. So they are more likely to have adverse clinical outcomes and be associated with, have more risk of having long COVID syndrome. So when we talk about social determinants of health, these all lead to increased COVID-19 susceptibilities, talk about lack of food services, lack of access to health services. All of these things are going to lead to an individual having being more susceptible to COVID. Okay, I tickled my throat. Okay, so we talk about COVID treatment. It must involve a recognition and validation of the individual's experiences, their symptoms, and life experience. Again, person-focused, comprehensive, coordinated approach. A provider must understand what barriers a patient is facing. Healthcare workers, the healthcare system lost 20% of its workforce during the pandemic. A study was done in the United Kingdom that reported that individuals at greatest risk of long COVID were aged 35 to 69. They were female. They were living in more deprived areas, and those individuals working in healthcare, social care, teaching, and education. So our healthcare system is fragile, and we really need to support healthcare workers who potentially have long COVID syndrome. What about nursing home unique issues? It's very interesting to me. Many residents are not able to communicate their symptoms. There's often lack of resources in nursing homes now. There's lack of support from outside services, and there's lack of education. So this post-COVID syndrome symptoms may not be recognized. And again, as I said, they may be thought of as other diagnoses and treated as such inappropriately, as in this case. A 78-year-old female, long-term resident of a nursing home, is diagnosed with acute COVID during the facility outbreak. Her symptoms are managed in the facility. After her isolation, she is found to have cognitive impairment, which is new. Her physician diagnoses her with dementia and orders donepezil. After the addition of this medication, she develops decreased appetite and has a weight loss of 18 pounds over 2 months. She sustains a fall while walking to the bathroom, which results in a femur fracture. So this may be a course of events that happens that practitioners, providers don't recognize as due to post-COVID. And then we've added a medication that may have worsened her loss of appetite, which causes her to lose weight, muscle mass. She has a fall, and then she has a femur fracture. So this cascade of events could have been prevented early on if maybe we recognize that it could be post-COVID syndrome, maybe refer her to a neuropsychologist. We give her some really good support. We really follow her weight loss. We get her with some supplements. We find out what she likes. All of these interventions perhaps could have saved this fracture. So there's a lot of cognitive bias surrounding long COVID syndrome. And so this stigma really impacts providers, and some providers have that stigma and don't believe that long COVID is real. So they don't take long COVID, patients with long COVID seriously. And I really love this quote, that long COVID challenges our belief in our institutions, because truly contending with what long haulers go through means acknowledging how poorly the healthcare system treats chronically ill patients, how inaccessible social support is to them, and how many callous indignities they suffer at the hands of even those closest to them. Long COVID is a mirror on our society, and the image it reflects is deeply unflattering. This is why I said I really feel like our most fragile individuals in our society have been thrown to the wolves of misinformation, and it's our job to really support them in any way we can. So as a reflection on our society, there's a belief that disability is not normal or expected. So there's a lack of support with individuals experiencing disability. Again, I stated it's really important to take these individuals seriously. Very important. There could be blaming physical symptoms on psychological issues, and the emphasis on work ethic devalues individuals who can't work. Some individuals cannot work due to COVID, long COVID. So these are some resources for patients. They're really wonderful, especially the Survivor Corps and Long COVID SOS. Really wonderful case studies and stories from individuals who are suffering. Some take-home points: it can present long COVID can present in a number of ways, affecting several organ systems. COVID vaccination can help prevent severe and acute COVID symptoms, and it can help mitigate post-COVID syndrome symptoms. This is important, and this is important that we educate the patients, the residents, and families that we take care of. It's important for providers to recognize the role health inequities play in post-COVID syndrome to reduce barriers to care. And it's important we utilize a patient-centered approach. We see the patient, we treat the patient in front of us, and utilize a shared decision-making to make our diagnosis and treat individuals who may have post-COVID syndrome. Thank you very much. We'll take any questions.
All right, so if you have a question or comment, please submit them using either the Q&A tool or the chat. And you can also raise your hand if you would like to ask your question out loud. And since we haven't gotten any questions so far, I'm just going to run through a few closing items. I'd again like to invite everyone to next week's webinar, which will be on the end of the public health emergency. We'll be breaking down the guidance for long-term care facilities, home health, and hospice. And that webinar will also be presented by Dr. Storm. And it will be same time and place next week, next Wednesday at 2 p.m. And it will be eligible for nursing CEs. I dropped a link in the chat earlier for a flyer that has more details and how to register. And I will drop that in again here in a moment in case you missed it. We also invite you to bring your questions to our virtual live chats every Tuesday and Thursday at noon. Deborah Wright will be there to answer questions on topics such as quality improvement initiatives, infection control, or MDS coding. If you're interested in attending one of our live chats or any of our other future webinars, you can find the links in our newsletter that we send out each Friday called the Last Minute Lowdown. And if you would like to receive that newsletter but don't think you're on the mailing list, you can email me at caudill@qualityinsights.org to get on that list. And I will also put that in the chat here in a moment. All right, I don't see any questions so far. Dr. Storm, was there anything else you wanted to add while we give people a moment?
I don't think so.
Well, let me put in the chat here in a second.
Feel free to reach out if you have any questions. Can email me. Be happy to help.
Okay, I just put in the chat your email and my email and the link to the flyer with more information about next week's webinar, which has CEs available for nursing. And I'm also going to be emailing everybody here later this week with the presentation slides that you had here today and the recording for this webinar and our contact information. So if anyone had a question or wanted the slides, needed these resources, wanted to visit any of the resources that you had in your presentation, you'll be getting that to the email that you used to register. And since we have not gotten any questions, I think we can go ahead and wrap up. Before we sign off, I'd like to ask everyone here to please answer a short evaluation of today's webinar. It will be anonymous and shows as a pop-up as soon as we close the webinar. So if you have a couple minutes to fill it out, we'd appreciate it. Dr. Storm, thank you for joining us again today. And we'd like to thank all of you for joining us, and we hope to see you back here again next week.